Thank you for the opportunity to be here to talk to you about multiple myeloma, and thanks for the nice introduction. I'm going to talk about the new consensus guidelines for diagnosis and response in multiple myeloma. I'm going to go over an overview first, and then we're going to go over the new guidelines for diagnosis, response, and then I'll take any questions. As you know, multiple myeloma is a hematologic malignancy that affects the bone marrow of patients and also the bones. And it is associated with multiple morbidity and mortality. There are about 100,000 new cases worldwide and about 72,000 deaths. The cases of myeloma are also expected to increase significantly in the next few years, mainly due to an aging population and possibly also to better diagnosis tools. The incidence rate of multiple myeloma in Asia is around 0.5 to 3 for every 100,000 people, and the average age of diagnosis is around 62 years of age. In North America, the incidence is higher. It's about 6.3 of every 100,000 people. It is higher also in African Americans, and the age of diagnosis is a little bit longer, usually around 69, 70 years of age. This plasma cell malignancy is marked by molecular heterogeneity. As you all know, not all myeloma is created equal. And there is a natural history of progression from MGUS and smoldering myeloma, which creates a unique opportunity to study this disease. Currently, the definition for myeloma requiring treatment requires that the patient has evidence of end organ damage or biomarkers of malignancy. And you have the biomarkers of malignancy listed here, and we'll go over them in a little bit more detail in the next few slides. You also have some subgroups through gene expression that detail the heterogeneity of myeloma. I also wanted to point out that we do have a new revised international staging system that is based on more than 4,000 patients from 11 international clinical trials. This was truly an international effort to do a new staging system for myeloma. This is based on 3,000 young and elderly patients that had data also for the international staging system, which is the older staging system that we used until a few years ago. LDH and cytogenetic abnormalities. And these patients were treated with modern era medications with immunomodulatory drugs and proteasome inhibitors, and the median follow-up was 46 months. And what you can see here is that the staging is based on the albumin, the beta-2 microglobulin, cytogenetics abnormalities, including FISH, and also LDH. And if you don't have any high-risk cytogenetic abnormalities, you have a serum albumin of more or equal than 3.5 and a beta-2 microglobulin of less than 3.5 with a normal serum LDH, then you're low risk. And if you have a beta-2 microglobulin of more than 5.5, any high-risk cytogenetics, which are defined as deletion 17p, translocation 414, or translocation 1416, or a high serum LDH, then your ISS is stage 3. And if you have anything in between, then you're stage 2. And you can see the overall survival for 5 years in stage 1 is 82% compared to 40% in stage 3. So this staging gives you an opportunity to identify those patients that do not have good prognosis and maybe to do some difference in the treatment so that they can have better outcomes. So it is an important staging system to all your patients using the clinic to stage them according to this. So we'll talk about the new guidelines for diagnosis. So this is a little schema here. Let me see if you can see. Okay. So this is the tumor burden from less to more. We've talked about MGUS and smoldering myeloma being natural precursors of multiple myeloma that needs treatment. And so the definitions have been in the past a little bit arbitrary based on studies of progression. So a long time ago, I think Dr. Kyle figured out that if patients had less than 3 grams per deciliter in the blood of M protein, less than 10% plasma cells, and no end organ damage, the risk of progression was significantly different than those patients that had an M protein that was more than 3 grams, that had more than 500 milligrams of protein in the urine. These are the monoclonal proteins, more than 10% plasma cells. And based on this was crudely differentiated into MGUS and smoldering. With time, we've figured out that this smoldering myeloma is actually also very heterogeneous, with subpopulations of patients that have lower risk to progression, very similar to MGUS, and some patients that are very similar to myeloma. And so the new definition for diagnosis takes into account these patients with smoldering myeloma that are close to this line here, where they would have myeloma requiring treatment, but they have not yet developed end organ damage. So for the diagnosis after the guidelines published in 2014, the main difference is that there have been some biomarkers that have been identified through different studies, mostly retrospective studies, showing that these patients that have, for example, more than 60% plasma cells in the marrow, that have an involved-uninvolved free light chain ratio of more or equal than 100, or more than one lesion on MRI that can be identified as myeloma, these patients have a risk of progression that is around 70–80% at 2 years. And through a consensus guidelines, it was decided that these patients should now be treated as myeloma. So any patients that have these biomarkers here should be myeloma. And on the contrary, patients with smoldering myeloma up to, I guess, 59%, although you can see this is also a little bit arbitrary, right? 59 is almost the same as 60, but you have to put the cutoff somewhere. So 10 to 59% plasma cells is still smoldering, okay? And you have the criteria here. I don't know if you have the slides, but, and basically these are the main changes. And this is just one slide reminding us of this definition of MGUS and smoldering. For smoldering myeloma, the average for transformation to myeloma is about, for 5 years, is about 50%. Again, there are some patients that do not progress here. Most of them do, but some of them do not. This is a very long-term follow-up, 25 years. So sometimes it's difficult to predict the individual risk. This is one of these publications that talked about having more or equal than 60% bone marrow plasma cells. So this was a publication from a retrospective study from the Mayo Clinic a few years ago that was published as a letter. And what the authors from the Mayo Clinic saw is that when they looked back to about 650 patients with smoldering myeloma, and they looked at specifically this biomarker of the percentage of plasma cells in the bone marrow, the ones that had less than 60% plasma cells progressed at a much lower rate than the ones that had more or equal than 60%. What you can see here is most patients that do have, 60% plasma cells in the marrow, most of the times they already have CRAB criteria. They already have the kidney dysfunction, or usually they have anemia. So it's a very small percentage of patients that have this degree of burden in the bone marrow and actually have not yet developed any symptoms from this. It's a very small proportion. It's 2–3% of all the patients. And this is what you see here. And I believe, there have been other studies published also later on after this was published, saying a similar thing, that it's also a small percentage of patients that they do progress quicker. The next one is the involved divided by the uninvolved free light chain ratio. So this is if you have a IgG kappa myeloma. This is the kappa by the lambda. If you have an IgG lambda, it's the lambda divided by the kappa. And it has to be equal or more than 100. What you see here is for those patients that had this biomarker that was more than 100, the time to progression, in this case, was around 70% at 2 years. And then this is the study showing that if you had more than one lesions on whole body MRI, that also this portended a significantly increased risk of progressing to myeloma in the following 24 months. And basically all of these 3 biomarkers, what they show is that the risk of myeloma is too high so that we would just establish treatment beforehand. So this is why the diagnosis for myeloma changed. So in summary, before 2014, what we used for myeloma that required treatment was the CRAB criteria, and after 2014, we're using still the CRAB criteria, but also biomarkers of malignancy. We're also going to go over the new guidelines for response very briefly. Why do we need new definition for response assessment for myeloma? Well, this is due to the fact that we have deeper responses with the novel medications, and we also have the need to assess for minimal residual disease. Using all the therapies, even with an autologous stem cell transplant, patients did not achieve complete remissions in most occasions. It was definitely less than 50%. But now using the novel therapies up front, using consolidation and maintenance, definitely more than 50% of patients achieve a complete remission. However, even those patients that have a complete remission, they still relapse, and this suggests that there is persistent disease that we cannot detect with the current recommended guidelines. And so these new guidelines were made so that we can go a little bit deeper, assessing minimal residual disease. In this response assessment, there really has been no change in the definitions of progressive disease, stable disease, minimal response, partial response, very good partial response, complete response, and stringent complete response. The only thing perhaps in progressive disease or relapse is that now there's a category that if you're minimal residual disease negative, then you can turn into minimal residual disease positive, and that will be considered relapse, but it is not a clinical relapse. So there is no recommendation to treat if you go from MRD CR, MRD negative to CR, MRD positive. There has been a big change in minimal residual disease criteria, which is the first time that we have this in myeloma. And there are basically 4 categories: a sustained MRD negative, flow MRD negative, sequencing MRD negative, and imaging plus MRD negative. These are basically the standard criteria that have been published very recently. And here you can see that this is very similar to what we've been using in the clinic, at least in our clinic at MD Anderson. And you can read this, but basically if you have a complete response, you have negative immunofixation and urine disappearance and any soft tissues plasmacytomas, and less than 5% plasma cells in the bone marrow. What we call a stringent complete response requires all of these things in the complete response, but then also that the plasma cells in the bone marrow cannot be clonal. And then you also need a normal ratio in the serum free light chains. For the minimal residual disease criteria, I'm just going to go over here a little bit. So sustained MRD is when you measure minimal residual disease in the bone marrow by next generation flow or next generation sequencing, or both, and also by imaging, with this definition where there is a disappearance of every area of increased tracer uptake found at baseline or a preceding PET-CT. And then this has to be for a minimum of 1 year. And then the subsequent evaluations, you can say 1 year MRD negative, 2 years MRD negative, 3 years, and so on. By flow, they have put this definition where there cannot be any aberrant clonal plasma cells. As you know, by flow cytometry, you can detect in a very sensitive way, especially with next generation flow, the number of aberrant versus normal plasma cells in the bone marrow, and this can be reported in the regular pathology report. Here, they want us to use the Euroflow standard operation procedure or similar, or equivalent method. So there are currently 2 methods. One is the Euroflow, which uses 2 tubes, 8-color flow cytometry. And then there's another one that we're also using, which is a 10-color flow cytometry, 1 tube. And they both have a sensitivity of around to basically found 1 in 10 to 5 cells that could be myeloma. For sequencing MRD negative, you need to have absence of clonal plasma cells by next-generation sequencing on the bone marrow aspirate. The presence of a clone is defined here as less than 2 identical sequencing reads obtained after DNA sequencing of bone marrow aspirates, using lymphocyte, platform, or an equivalent method. And the minimum sensitivity is also 1 in 10 to 5 cells. So currently, we're not using sequencing at MD Anderson for minimal residual disease detection. However, there have been many studies showing that the sensitivity of sequencing is better than flow cytometry. So we are actually working now to get sequencing at MD Anderson, and currently what we do is minimal residual disease flow. So far, it is not changing what we do if the patient is MRD positive or negative. For example, if a patient finishes transplant and consolidation treatment and then their CR MRD positive or MRD negative, we still give them maintenance to both of them. So I think that in the future, I'm not sure if this is going to change, and there are many ongoing studies now evaluating what is the role of minimal residual disease in the treatment, to see if treatment needs to be stopped early if you're a minimal residual disease negative, if you need more treatment if you're positive, and so on. For imaging, we do use a lot PET-CTs, especially to detect. Sometimes there is hidden disease. If a patient is going to transplant and they have had prior extramedullary disease, we usually check a PET-CT to make sure that there's nothing left before they go to transplant. In this case, for the criteria, you need to have disappearance of tracer uptake for myeloma for a patient to call them incomplete remission, basically. And for that, you either have to do a PET-CT at diagnosis or at relapse, when they relapse, and then if they have any areas of uptake in the bone marrow, or if they have lesions somewhere else, or extramedullary disease, those have to go away. And it's actually the PET-CT, I do think it's very useful for myeloma. There are actually several studies, I believe at ASH also. There was a publication talking about the usefulness of PET-CT in myeloma. And it's something that we use quite a lot. Okay, any questions about this? No.